Hello, and welcome to this Clinical Pharmacology and Therapeutics podcast. This is the first of two podcasts on antiplatelet agents and anticoagulants. During this podcast, I'm going to talk about antiplatelet agents. In particular, I'm going to talk about aspirin, Clopidogrel, Dipyridamole, and the GP2B3A antagonists such as abciximab and tirofiban. I'm going to use these agents as a way of illustrating some of the most important mechanisms by which antiplatelet agents have their actions in both primary and secondary prevention of ischemic disease. So first of all, let's talk a little bit about the general indications for starting someone on an antiplatelet agent. We're going to talk a little bit later about some of the specific indications for each agent, but let's first briefly talk about these general ones. So, first of all, the most important general indication is in the acute prevention or the acute treatment of coronary events. And I'm sure many of you will be familiar with the use of, for example, aspirin, either alone or together with Clopidogrel in the management of acute coronary syndrome. We can also talk about these agents in the context of both primary and secondary prevention. Just to clarify, primary prevention is when we give a patient an agent to prevent them developing a specific disease, while secondary prevention is when they've had an event or have a disease state. We give a agent to improve the prognosis of this condition. And important examples of where antiplatelets are used in secondary prevention are following cardiovascular events, for example, following acute coronary syndrome, following cerebrovascular accidents, transient ischemic attacks, or in patients who have peripheral vascular disease. Antiplatelets can also be used in the context of atrial fibrillation. Now, if you remember, in atrial fibrillation, we usually use warfarin, but for some patients this is unsuitable because, for example, they wouldn't be able to stick to coming to clinic times to have their INR checked, or perhaps because they're at risk of falls. And in these patients, aspirin in particular has been shown to be a suitable replacement for warfarin. Lastly, the last situation is in valvular replacement, and we'll talk a little bit about that later. So first of all, let's talk about probably the most commonly used agent, and something that if you look at most patients' drug charts, you'll find they are on. This is aspirin. There are two kind of doses of aspirin that you need to be familiar with. There's the larger, more anti-inflammatory dose, the dose of 300 milligrams, which is used for patients in pain and can be used also in pyrexia. And there's the smaller 75 milligram dose, which is by far the more common dose used. So I'm sure many of you will be familiar with the mechanism via which aspirin works. Basically, it is an irreversible inhibitor of COX, particularly the 1 and 2 isoforms. By inhibiting COX, you reduce synthesis of prostaglandins, and as you might remember from your pathway of platelet aggregation, prostaglandins are very important in stimulating and maintaining a pro-aggregatory state. Aspirin also has a preferential inhibition of platelets, and this is mainly because platelets are a nucleate and they're exposed to the aspirin in the portal blood. So, what are the indications for aspirin? As we've already said, the higher dose of aspirin, that's the 300 milligram dose, is most commonly used for patients in mild to moderate pain and pyrexia. However, most commonly you'll see aspirin used in hospital patients for primary and secondary prevention, particularly used to prevent the development of atheromatous disease, for example, myocardial infarction, ischemic strokes, and TIAs. The reason for this is that often the event that results in these disease phenomena is the dissolution and rupture of an atheromatous plaque, which is very pro-aggregatory and will lead to the formation of a clot through stimulating platelet aggregation and then clot formation. So by giving the patient an antiplatelet agent, such as aspirin, you reduce this risk considerably. It's important when we think about aspirin to think about the adverse profile, particularly with the case of aspirin, because one of the most important side effects of aspirin is bleeding. And this is the reason that patients, say, with a history of gastric ulceration will not be prescribed this medication. Other important side effects are bronchospasm. This is due to the effect on leukotrienes. And aspirin has also been known, particularly in the higher dose 300 milligram form, to precipitate gout. In terms of contraindications for aspirin, obviously a history of GI bleeds is a contraindication. A history of other bleeding diatheses, such as haemophilia, is also a contraindication, as is the presence of asthma because of the risk of bronchospasm. Finally, it's recommended that children under the age of 16 are not given aspirin because of the risk of Ray's syndrome. This is a syndrome which results in encephalitis and acute liver failure. It's recommended, therefore, that these children of this age use paracetamol. In terms of important interactions, obviously, because aspirin can cause bleeding, you don't want to use it with other anticoagulants or antiplatelet agents unless absolutely necessary. And other idiosyncratic interactions include with methotrexate, where there's an increased risk of toxic effects of the methotrexate. Let's move on now to talk a little bit about Clopidogrel or Plavix. This is a thienopyridine and is the second biggest selling drug worldwide, mainly because of the evidence now for its use in the context of acute coronary syndrome. Its mechanism, essentially, it irreversibly blocks the action of ADP on a specific receptor on the platelet surface. This is the P2Y12 receptor. This ultimately results in reduced aggregation of platelets. It's been shown in studies to be a slightly more effective antiplatelet agent than aspirin. However, it is a lot more expensive. You also need to remember that Clopidogrel requires a loading dose, typically 300 milligrams. This is the reason that in the context of acute coronary syndrome, you give 300 milligrams of aspirin and 300 milligrams of Clopidogrel. Its usual dose, however, is just like aspirin, so 75 milligrams. Important indications are, as already mentioned, the ACS protocol, where you give the 300 milligrams of aspirin and the 300 milligrams of Clopidogrel. However, it's also used post-coronary stenting, where, once again, it's given together with aspirin. And finally, it's used as an alternative where aspirin is contraindicated, say in a patient with a history of gastric bleeding, or where it's poorly tolerated. In terms of the adverse profile, we have a very similar picture to that for aspirin. However, it's important to note some particular idiosyncratic side effects that are particular to Clopidogrel. These are bone marrow suppression, particularly neutropenia. However, remember that side effects to do with bleeding are rare with Clopidogrel. So let's talk a little bit now about two of the rarer agents that are used for their antiplatelet effect. First of all, let's talk about Dipyridamole, which is a phosphodiesterase inhibitor. This works by increasing the cyclic AMP that's found within the platelets themselves. This ultimately leads to a number of signaling pathways to decrease release of pro-aggregatory agents, therefore has overall a anti-aggregatory or anti-platelet effect. Its particular indications are for secondary prevention of stroke, particularly in patients who've already had a stroke on aspirin, and this is the most common setting in which you'll see this agent used. Other indications are for prosthetic heart valves, and it's often used as an adjuvant to normal anticoagulation, say with warfarin. In terms of its adverse profile, there are a couple of things in each category to be aware of. In terms of side effects, the most common side effect is headache. In terms of contraindications, this is a drug that should be avoided in myasthenia gravis. And importantly, Dipyridamole has an interaction with adenosine, prolonging its effect. So lastly, let's briefly mention the glycoprotein 2B3A antagonists. These agents include things such as abciximab and tirofiban and are the newest of all these agents. Essentially, these are monoclonal antibodies against the 2B3A receptor. This is a receptor found on the platelet surface that is very, very important in platelet aggregation. Therefore, by blocking the receptor, we reduce platelet aggregation. The number of trials going on with these agents in terms of where exactly they should fit into our armory against atheromatous disease, but at the moment, they're mainly indicated in the context of percutaneous coronary angioplasty, either in very high-risk patients who are awaiting angioplasty or for those undergoing angioplasty. In terms of the adverse profile, contraindications are as for the thrombolytics, which I'm going to go on to talk about in the next podcast, but important side effects to be aware of are particularly bleeding. And this is why, for example, it's very important after angioplasty for patients who are on these agents to watch for bleeding from the sites of the angioplasty itself. And obviously, of course, they interact with other anticoagulant and antiplatelet agents. So that's really a quick run through these agents. We've looked at the most common and important agents, such as aspirin and Clopidogrel. We looked at the indications, both in the acute setting and for primary and secondary prevention. We've looked at where precisely these agents act within the platelet. And lastly, for each agent, we've talked about the most important adverse effects that you need to be aware of. So thanks for listening to this podcast. In the next podcast, we're going to be talking about anticoagulants and thrombolytics. So see you soon.